E partirei con la lettura magistrale del nostro amico Mike. Mike, if you want to come. E lo ringraziamo per essersi accollato questa lettura magistrale. Mike Robson ha una visione di presentazioni, lo conoscete benissimo perché ormai è triestino più di noi, e ci parlerà in questa lettura magistrale, sempre nell'ambito della gestione per ridurre i rischi e le complicanze materno-neonatali. Ci parlerà di Simplicity, the key to safety, quality and reduce litigation in labor world. Thank you, Mike.
Thank you, and good afternoon, ladies and gentlemen. I do want to say, first of all, thank you for inviting me again. It's a privilege that I don't take lightly, and I hope, like in previous years, I will be able to stimulate some thoughts and some discussion. One of my close friends once said to me, Mike, you know, the thing about you is you give the same lecture every time, you just change the title. Now, I hope it won't be quite as bad as that, but I hope that you will have develop some new thoughts from what I say, and maybe something that we could all take back with us and share our experiences. Litigation. This is the NHS. This is something that was published and is available on the net, and I think it's well worth having a look at. Some of you may have seen it already. 10 years of maternity claims, analysis of NHS litigation authority data. And really what it does is, if we go back there, yeah. What it does is look at the claims and the cost of the claims, and they present it in different ways. So these are the total number of reported claims, the actual claims, and you can see there that obstetrics and gynecology rank very highly when compared with the individual other specialities. But when you look at the total value of all the claims, you can see that obstetrics and gynecology are well out on their own. £5 billion over the years 95 to 2011. Again, this is another way of looking at the total percentage of reported claims, but this is looking at the denominator of all the other specialities. You can see that the number of claims are significant in obstetrics and gynecology, but again, if you look at the value of the claims, it's over or nearly half of the money, and it's a lot of money. Now, I'm presenting these figures really just put the background to what I'm going to talk about, and I'm sure, I don't know whether there are equivalent figures in Italy, but I wouldn't be surprised if they're quite similar. Sorry. Now, if we also look at the table here, and this is a breakdown of all the maternity conditions. Now, some of these conditions aren't defined mutually exclusive and totally inclusive. Mutually exclusive. Caesarean section, cerebral palsy, CTG interpretation, management of labour, shoulder dystocia, and uterine rupture. And these are the number of claims. These are the percentage, and this is the money. But they are the main obstetric claims. And really what I want to do is look and take those as a background and to see whether we can think about what we're doing at least, because it seems from this at least that we're not doing very well. So how do we assess quality of obstetric care? Primarily safety and outcome. Safety is and deserves a special, a separate issue. You could say safety is part of our outcome, but safety is important as an entity, and it's becoming more important and is what everything else is based on. We could look at what else affects the quality, and certainly the structure, the building, the equipment, and the staff, all coming under resources. We could look at the processes or the guidelines. A lot of units and a lot of organizations regards this as a way of judging quality. So rather than looking at outcome, you just look at whether you've got guidelines for everything and how often they're implemented. And that is one considered way. And certainly in the UK, the CNSST and a lot of other quality and national agencies look at whether you have process or guidelines in place. Organization, particularly important, and again is very important in judging quality of care. Is there a true philosophy in the unit? Is there a leadership? Is there a truly multidisciplinary approach? Is there good communication? The key processes and decision making, and I'll come to that in a minute. There are some key decision making processes in the labour ward and delivery, and how well are they managed? The professional's knowledge of information, the ability to respond and change to information and outcomes, the ability to perform, and also what I like to refer to as fail-safe mechanisms. So within an organization, if it gets past the first stumbling block or the first barrier, is there another mechanism that actually picks it up? These are some of the key processes and decisions in labour and delivery that I think are very pertinent, and something that if you were going to make a judgment on quality and safety in a delivery ward, how a pre-labour caesarean section is decided, at what level is it decided, the same with induction of labour. The diagnosis of labour, is there a very simple way and repeated way that we can make that? Probably the most important decision in obstetrics. Maternal and fetal well-being, how do we judge that on the labour ward? How do we monitor? Is the way we measure or care for the fetus the most important thing, or is it the results? When do we rupture membranes? How do we rupture membranes? Does everybody agree when we rupture membranes? Could you ask somebody what our policy is on rupture membranes? The use of oxytocin and philosophy on dystocia, which I'll be coming back to. The management of the second stage, operative delivery, and the management of the third stage. So these are all key decision moments, if you like, during labour and delivery, and a very good way that you can measure quality and safety and quality on the delivery ward. So I would put you that quality is measured by safety and outcome, and the structure, the processes, the guidelines and organisation respond to and directly affect quality, because we have to see it through the eyes of the woman and which of those actually are most important. Women and professionals, I think, fundamentally are interested in safety and quality, and ultimately that's the biggest decision factor that you judge. And ultimately, safety and quality is related to outcome, and it's outcome that guides processes. We are, at the moment, in the middle of a vogue going through that we must try and standardize processes and find out what the best processes are, either through randomized controlled trials or other ways. And then there are many that assume, because we're carrying out what is perceivably evidence-based evidence-based processes, that we assume that the outcomes will be appropriate. I think we've got to think a little bit the other way now and to try and look at outcomes, because that's really what most people are interested in. And it's not only physical outcomes, but it's also emotional outcomes, which sometimes is left a little bit behind. So putting it all in all, and with the list of the claims and all the efforts over the last 10, 20 years, recognizing that, even the data from 2012 shows that it isn't working. I don't know whether everybody here feels we're getting better. Are we getting better? Or is there something missing? And if something is missing, why is it not working? Do we think we're on the pinnacle of how we're going to improve quality or attain quality? Are we still getting better? And if we are still getting better, where were we before? It's difficult to judge, and I think, we all have our own opinion, and maybe this will come up with the questions, but I don't think we're there, and I think there is something missing, and I don't think anything is going to change very quickly unless we fundamentally rethink how we're doing things. This is what I'm interested in, simplicity. I think that, and it is personal opinion, I accept that, and you can shoot me down later if you feel. I think we've made things so complicated in everything we do that we're losing the run of ourselves. We're going round in circles. And I think we've got to fundamentally rethink it. And when I talk about simplicity, I'm not saying it should be just a sentence or something. There's more to simplicity than just keeping something brief. It's about a clarity of thinking, a simplistic way of thinking, a way of thinking that all of us can understand. Was it Einstein that said it should be such that a 6-year-old should be able to understand it? Leonardo da Vinci, simplicity is the ultimate form of sophistication. And I think these are the things that we need to look at. If you look at good sports teams, good organizational teams, they have very, very simple philosophies that are repeated through all the members of the team. And we are really a team in that sense because we've got a lot of different specialities. And I want to give you 2, 3, 4 examples here, if we have time to go through it, where I would say we're not doing well in terms of achieving that simplicity, that clarity of thinking. Standardize the audit of perinatal outcome. And don't worry, this isn't going to be about the 10 groups, but it would have to come up somehow or other. I do think we need to improve that we look at results. We have to classify all our outcomes so that we can compare objectively between different units and in one unit over many years, both nationally and internationally. We need a consistent and objective and overarching structure classification which we can examine these outcomes. But it hasn't happened up to now. It really hasn't happened. And I think some of us have had to, if you like, push this to the top of the agenda and start asking people, why hasn't it happened? I mean, it's the most basic of all things is to look at what you do. It may not be a very high standard. It may be not as good as you want it, but you should know what you do. Principles involve the fact that overall rates of any events or outcomes are on their own meaningless and may hide things, and that no perinatal event, and that includes caesarean section or outcome, should be considered in isolation from other events, outcomes, and organizational issues. The 10-group classification system, many of you just think, oh, that looks at caesarean sections. It's going to be much more than that in the future, but it's something that will bring us all together, something that we can identify as a brand, if you like, and that we can start. And that's what it is, a common starting point for more detailed analysis. And some progress has been made in this, and we publish our own reports, but there are other units now in other countries publishing their perinatal data, which enables us to learn from each other. The WHO have come on the back of this, and they have supported, and they mention their caesarean section rates need a universal classification system. Everyone has got their own agenda, and the WHO have come from that direction. But on the other hand, they also have in that declaration last year, or this year actually, said that we need to look at all outcomes, not only caesarean sections. And they're going to assist in making that happen by developing a manual. FIGO have now also recognized it, and the recommendations that they made recently at Vancouver was that all institutions should institute it for looking at caesarean sections, that FIGO encourages the results to be made available for purposes such as quality control and auditing, and FIGO encourages maternal and neonatal events and outcomes, including morbidity or mortality, to be recorded and made available according to the 10 groups. Now, yes, in a way, it's not simple, you could argue. You've got to divide things up. But on another hand, it's pure simplicity because it's a clarity of thinking that can join people together. And the simplicity mustn't be taken at its face value, that you're just trying to replace everything by a simple sentence. It's more a clarity of thinking that the simplicity is there. And it provides the ability to share, compare, and learn from one another. And that's really what I think is so important. Oxytocin and labor. Of those list of those things, oxytocin really is something we have to focus on. There are a lot of guidelines out there, and the guidelines really probably include 2 things mainly: a clinical decision-making process, which is very understated in most guidelines, and a dosing regime, which is very overstated in my view, and a lot is made of it. Yes, it has to be safe and simple. And yes, whatever the overall guidelines suggest and where the variations in dose may be, in one unit, there must be only one way of giving oxytocin. Whatever that unit decides, so be it. And there will be variations, but there has to only be one way, and that should cover all women. There's confusion about what uterine tachysystole is, the overcontracting, hypertonus, also there's certain confusion, and hyperstimulation and where they overlap. But if we are going to use a drug, which is considered one of the 10 alert drugs or whatever they call it, it's a serious drug, we've got to know something about it, and we've got to know a little bit more and use terms that we all agree with. Concentration, starting dose, incremental dose, rate of increase, maximum dose are really not the issue, but that is what most guidelines go on about, the different doses, the different rates, the different things. What they don't spend time on is the issue, which is really important, is the effect on the fetus and the uterus. How often you're using oxytocin, how often you need to reduce it, and the consequence on other perinatal outcomes. And this is what I think is the most important bit about the oxytocin bit. I have seen guidelines where they say 5 and 10 contractions in 10 minutes is normal. In fact, the NICE guidelines, and this is where this kind of indecisive, lack of clear thinking, says 4 to 5 contractions in 10 minutes. Whenever anything says 4 to 5 minutes, it just hits me in the face as not simple, not easy to follow. So I would suggest that you go back to your guideline in your unit and tell me that if it's 5 contractions in 10 minutes, does the oxytocin go up, does it go down, or does it stay the same? Is there a clarity of message of either the midwife or doctor of what to do? And why, when oxytocin is far more significantly involved in ruptured uteruses and other problems, is the rate of contractions, when on oxytocin, considered reasonable to be the same in nullips and multips? The beauty about 7 contractions in 15 minutes as opposed to 5 and 10, if it's 7 contractions in 15 minutes in a nullip, it goes up. If it's 8 contractions in 15 minutes, it comes down. That is simplicity, that is clarity of thought. And just like in multips, where we put everything in the way, and we should be very respectful of using oxytocin in multips, we should have a lower dose, 5 and 15 minutes, when they're on oxytocin. This has the advantage of a longer period of time to assess the contractions, over 15 rather 10 minutes, and less maximum contractions over 30 minutes. And I think oxytocin should be standardized. Ultimately, whatever dose you use, whatever other way you do it, that the effect that it has on the uterus, obviously the CTG is a different lecture altogether, but on the uterus it should be very standard and very clear message, and it isn't. They go on about artificial rupture membranes, and when you do that, and remember, when you rupture your membranes, will have a big effect on oxytocin regimes. If you leave a very long time to rupture the membranes, and you have a low dose and it goes up very slowly, you might sometimes never get to the maximum dose. But anyway, that's going into more detail than I meant to do for this lecture. As I've said, there's got to be clear difference between nullips and multips. Same oxytocin regimen is fine, but the response must be very separately measured and different. The clinical decisions for the guideline, when to start it, who starts it, which women do we never give it to, are also important, and that's also part of the guideline. But there must be direct, simple messages. Those people can start it, those people can't start it. Those situations we do give it, those situations we don't. Not maybe, depending whether the sun is shining or anything else. Simple, clear messages. It is a dangerous drug. It's about time we treat it as a dangerous drug. And unless we all order oxytocin in a standardized fashion, we will overuse oxytocin, use it when it's unnecessary, use it inappropriately, and maybe also not use it when we should. If you don't know how often you're using it, in who you're using it, how you're using it, or what the overall perinatal outcome is in those you do it, then that, in my opinion, is poor quality and it isn't safe. We know oxytocin causes problems with those medical legal cases, but all of you go back and see if there are simple messages about who to use it and not, and do you audit it. VBAC is the next situation. You saw in that medical legal report there were a lot of uterine ruptures, And there's all kinds of scoring systems about VBAC and how you should deal with it and the predicted success. Yeah, to me, they may explain why there's variable success, but to me also, there's no usefulness in deciding management. It won't make any difference to me. I think we should all aim for spontaneous labour. Very simple message, very clear. I'm not saying they all have to, but that's the message we should give. If not in labour by 41 weeks and cervix unfavourable, give a date for caesarean section. Induction only if cervix favourable, ARM, rupture membranes, and wait for 24 hours maybe. And prostate and misoprostol are not given. I really think that's a very simple message, it's a very clear message, and it's a very safe message. We cannot afford to have ruptures of the uterus after giving prostaglandin and misoprostol. It doesn't fit. ARM on the diagnosis of labour, very simple. You negotiate with a woman and explain it. We do need continuous electronic monitoring. Fetal heart rate abnormalities treated by caesarean section. No fetal blood samples, no looking and lasting. If you're going to try and persuade women to go into labour, that's a very simple message. But once they're in labour, make sure that there's absolute consistency in how you look after them. When could you consider oxytocin? Well, I think instead of nulliparous women, where you want to give it early and safely because inefficient uterine action is a very high chance and very safe to treat in nulliparous women, in multiparous and multiparous with a scar, it's very different. So you should wait as long as possible before you give oxytocin. You should have evidence of poor contractions, and people must realize that, and they must have written that there's evidence of poor contractions. That there must be a favorable abdominal and vaginal examination by senior medical staff. So not everybody can put up oxytocin. It has to go past a senior member of staff, and then it has to be discussed with a consultant. Believe that oxytocin should only be given for 2 hours unless delivery imminent, and no more than 5 contractions in 15 minutes while you're on oxytocin. Now, I know a lot of people will say, yes, but women often contract more than 5 and 15 with a previous scar when they're not on oxytocin. Why is that wrong when you're giving oxytocin? Well, that's the problem. You're giving a drug. You're in unknown territory. You don't know where you are. And that is the danger with giving a drug. And do you know what? I would swap tomorrow, any day, for more women to go into labour, rupture their membranes, and it falls out, rather than give oxytocin at all. And I think the next message, certainly on the labour ward that I'll be working on, will be we remove oxytocin completely from previous scars. The beauty of it is it's a clear message. Sure, there'll be somebody arguing logically and academically and this way or another, but they're also not necessarily the people that take responsibility. We cannot ignore those figures that I presented in the first slide. And I love it when people take the incidence of rupture of uteruses over the total denominator rather than taking it over the denominator that actually were in labour, or even more so, the ones that had oxytocin. You'll find out that that percentage is a little bit more striking, shall we say, when you look at it that way. Antenatal class is essential. This has to be agreed with the women. They have to know what's happening. But if you put that forward to most women, remember, everybody can understand it. It's a clear message. And I think most people will buy into that because at the end of the day, it really is very much like common sense. What influence does the previous section have? Previous dilatation, indication, repair, nothing to me apart from repair. I don't think those first two make a difference. And it's certainly, whether academically it's a higher or lower chance of delivering vaginally, that may be so, but it still wouldn't prevent me advising spontaneous labour. Repair, or problem with the repair, and it was difficult to repair, would, however, and that's something that maybe should exclude. Estimated fetal weight, no difference at all. I wouldn't try any harder with a small baby if progress isn't occurring, as opposed to a big baby who is progressing very quickly. Progress is what should be regarded as normal, and epidural is not a problem. What are the risks? Rupture, and it's the unpredictability of that. So that's why removing all of those other factors will help in providing a safe and easy to understand. The mother understands it, the staff understand it. It's a simple way of thinking, and it's a clear culture that could be endorsed on a unit. Lastly, just shoulder dystocia, and we've been had a great time today going through, and I really enjoyed it. I hope everybody else did. And again, in terms of clear thinking and simple message, you've seen all those mnemonics that you remember about helper and things. And look, I'm not for one moment saying that if you find it useful, you shouldn't use it. But I can only remember some certain things, and 4 things, 5 things, maybe even 10 groups, but 4 things anyway I can remember. And the key things I would like to suggest you remember with shoulder dystocia, and the most important one is the first one, is don't panic. Most people will be able to remember that if they tell it, but you'd be surprised how many people don't remember that. The second thing is you want to know when was the delivery of head, which way is the baby facing, and how many attempts have been made to deliver with downward traction. That's if you come in after the event. You need to think all the time, this is going to come out with rotation after you've failed to deliver rather than traction. And the last thing is work together, all work as a group together. These are just some diagrams, and we went through this today, and this is just to kind of show the basic principles of depending on which way the baby is facing, you should use the left hand, and if it's facing the other way, you should use the right hand. But you have the right hand sweeping over the top and the left hand sweeping underneath. This is delivery of the posterior arm, and this is delivery of the right posterior shoulder with the right hand. So you swap arms, and I think that's a very important, simple, clear message to train people to do. Because when you are in these difficult situations, you need to think very simply and very clearly. And if you've got a lot of things to think about and all different names for different maneuvers and things, I will put my hand up, I can't remember. At the end of the day, if it works for you, that's fine. What we're trying to do is make something that will work for most of the people involved. So we suggest a two-handed approach to the manipulation of shoulders delivery. Left OA baby facing to the mother's right, the right hand sweeping across the top, right to left, and the left hand sweeping underneath, right to left, and the RO baby opposite. And this is it in just diagrammatic terms. You may put 2 fingers, you may put 3 fingers, but it's to get access behind the shoulders and to try and turn the baby. So turning and delivery of the posterior shoulder, clear messages and how you do it. And also a clear and simple way of thinking in the timeline of a vaginal delivery. And this is something which is quite different to what anybody else has looked at. And we developed this in our unit in order to try and get the working together, because shoulder dystocia may occur when you're there, or it may occur before you've got there, and you've got to come into the situation afterwards. And it's clear to us that we have to know what we're doing and when we're doing it and how they're related to one another. So what we do now is every delivery that takes place in our labour ward, we have the delivery of the head and we record the delivery time in minutes and seconds. Every delivery, not just the shoulder dystocia. We think which way the baby is facing and we wait for restitution and wait for the next contraction. But we know minutes and seconds. And the seconds, unfortunately, is important because if it's not 1 second or 58 seconds, it's a difference. The first contraction, whenever it comes, and I've just put 1 minute, it may be after 2 minutes. The first contraction when it comes, attempt first normal downward traction with Mac-Roberts and superior pressure if concerned, but just a normal attempt to deliver. And if no success, you wait for the next contraction. But the important thing there is, even though you may not suspect shoulder dystocia, because it hasn't come with the first attempt, shoulder dystocia is declared. You need to call everybody in early rather than late, but you have to have a point in time, a simple, clear way of thinking, an objective event that you say when people come in. Does that make sense? If you don't have that, then there's drifting. There's the 3 to 4 centimeters. There's this kind of no decision. You declare shoulder dystocia. So the second contraction, whenever it comes, it can come after 2 minutes. It may be 3 minutes. But this is over this timeline of about 4 to 5 minutes, which you have. The second contraction comes. You can decide whether to attempt a second downward traction or go straight to a manipulative procedure. After the second downward traction, no more downward traction. That's a very important and clear way of thinking. People remember numbers and they remember things like that. So if a midwife has done 2 attempts to deliver down and I come in, I can't start again and use my 2 attempts. The 2 attempts have been used. Everybody knows that. Everybody's singing off the same hymn sheet, because it's the continuous downward traction that may either cause the Erb's palsy, possibly, or certainly, if we have done it, we will be told we caused the Erb's palsy. Whether or not it actually did or not, etiologically, a lot of people discuss. And then, if that fails, at 2 to 4 minutes, proceed to use other rotational procedures or delivery of the posterior arm. And the delivery and access of either rotation maneuvers or posterior arm, you need to go to it at a time where you've got a little bit of time to get access. If you leave it very, very late at 4 to 5 minutes, again, panic ensues, and you're really trying to do it, because the issue is to get access, and access does take a little bit of time. And if people don't get access over 3 or 4 seconds, they panic and they try another maneuver or whatever. You just got to keep the pressure and just get access. And once you've got access, either try a rotation movement, as we did in the workshop today, or indeed deliver the posterior arm. And remember which way the baby is pointing, think also which hand you should use. And delivery of the body should have taken place by 4, but that allows another minute, probably 5 minutes. Having this timeline has completely changed how we approach things on the labour ward. And I was very surprised in the thought that minutes and seconds, that would never catch on. But it really has got caught on. And I would come in at, say, 2 minutes, 3 minutes or whatever, and I'll be told, well, Dr. Robson, this lady delivered her baby head 2 minutes and 37 seconds ago. We've had 1 attempt to downward traction, and that's where the situation, the baby, they sometimes even tell you which way the baby is facing. So you know actually what you do, because what you do and when you do it really is dependent. So arrival after the baby's head, when was delivery of head, which way is the baby facing, how many attempts have been made to deliver with downward traction? Times are crucial. It focuses your mind and it influences what you do and when you do it. And if any of you have been in a recent shoulder dystocia, when you came in, did you actually truthfully know how long the baby had been delivered, or the baby's head? And would it have at all affected which one maneuver you went to? This is probably more important than everybody thinks it is, really, is that traditionally there was just a blank page to write your notes on shoulder dystocia, and the poor old person whose patient was, usually a midwife, would have to go with a blank page and write her notes. This is important to make sure that anybody that's looking at the delivery afterwards can look at those diagrams, and yes, we've got the names of the actual procedures there, but the names aren't really important to me. It's the diagram to show actually what was done. But not only does it provide good documentation, which people can look and see exactly what happened, it will also reinforce and reinforce and reinforce every time 2 or 3 people fills it in of what they need to do. And I'm a great believer in using a resource of people's times to 2 or 3 things. So it's a training thing, it's a documentation thing at the same time. And I think the diagrams make all the difference. So, life is really simple, but we do insist on making it complicated. I would suggest to you that you all go back and try and think, can we make things simpler? Can we make things simpler in terms of clarity of thought? And can we just say, let's get some consensus? You'll never get a situation where it's absolutely right or wrong, but if you can get a clarity of thinking, which I synonymize with simplicity, I think the labour ward will be a lot safer place. Thank you.
Direi ringraziamo il professor Robson per questa splendida lettura magistrale, anche se teoricamente non è prevista alcuna domanda, però se dall'uditorio si vuol chiedere qualcosa, aspettiamo 2 minuti, un attimo, per fare domande.
Siete timidi perché non conoscete Mike? I have 2 questions for you.
Yeah.
So I think that your simplicity is very nice, first of all. But as for you discuss about the VBAC, okay, and you told us that your dosing regimen of oxytocin is no more for 2 hours.
When you give oxytocin,
What does it mean?
What does it mean?
So for example, I have a lady in labor, not in labor. The contraction is not so good. Rupture of membranes, and I have 2 to 3, 2 contraction is not progressing so much, okay? And I think this is very important to understand whether the previous section was done in labor or not.
That's too complicated for me.
So your question is after 2 hours C-section?
Yeah.
I do not agree.
No, well, I don't mind. I mean, I'm not saying this is not about agreeing. I'm saying, clarity of thinking. Clarity of thinking. If you say 2 hours, usually, if they were declared in labor, they should deliver after 2 hours. That's the first thing. And the second thing is, say whatever you want, 3 hours or 4 hours. But the longer you give oxytocin with a previous scar, there are risks. So you've got to weigh things up. Just look at those ruptured uteruses. Just look at those cases. I think ruptured uterus, when oxytocin is being used, I mean, I wouldn't sleep for weeks. I just think, there's no doubt, put it whatever way you like, you've given oxytocin and caused the rupture.
No, my question is, is depending how much is the dilation of the cervix, because if I am in 3 centimeters, it's completely different than 7 centimeters. And on 7 centimeters, 2 hours is okay.
Cervix what?
3 or 7,
yeah,
dilation is not the same.
Actually, that brings up another point. We would never give oxytocin after 3 centimeters in a previous scar. Because in a multip with a previous scar that's got to 7 centimeters over a number of hours, they've shown efficient uterine action by definition. Now, this is the issues that we're talking about. I'm not necessarily saying I'm right and you're wrong. I think academically, you probably could support your argument better than mine. What I'm trying to say, I would swap that for the simplistic, clear thinking that can be communicated consistently to a large number of people. That's what I'm saying. And then, as you all know, we look at our results.
Okay. The other
and we say the section rate versus the rupture rate versus the and if you've got great results, I'll be the first one over.
So the other point, you told us that it's important, as for the VBAC, the type of repair. What do you mean about that?
I think, look, a previous scar is a previous incision in there. So really what I mean by, not a small angle tear or something like that, but, if there was a real problem with recovery, if there was a T-shaped incision, if there was, a real problem with the repair. And to a certain extent, depending on what the operator actually put down, yes, it is subjective, I agree. But if, as most sections are, straightforward, I think that's fine. What I was really trying to do was be partly controversial, but partly say that we spend a lot of time talking about whether they got to 3 centimeters or 4 centimeters or 6 centimeters, or even the indication for the previous section. But the repair isn't given as much, thought to. And often a lot of people wouldn't even get the notes out to actually look at the repair.
There's a question from
Hey,
John.
Mike, as always, what a great lecture. I learned so much from your talks. Just on the same topic as in VBAC and the type of incision repair, as a fetal MFM specialist, we look at lower uterine segment thickness. And sometimes we get called in because ultrasound showed the previous cesarean section scar looks thinner. And there's some data, a lot of retrospective data, some meta-analysis suggesting certain thickness of lower uterine segment is associated with high risk of uterine rupture during VBAC. What are your thoughts, and do you do anything like that in your unit?
No, Joe, and I'm surprised more work hasn't been done in that area. I think thickness and thinness is more difficult, but as we all know, there are some cesarean sections that have a defect. And I think, as I understand it, and I'm not a specialist ultrasound person, that a defect you can pick out and you would probably not allow her to labour. You may indeed section her a little bit earlier than 38th and 9 weeks. But with the thinness, I'm not quite sure. There's going to be a lot of overlap, I think, between what you would have to and what you're doing unnecessarily. So I'm not quite sure there. That would be my own views. But I am surprised more work hasn't been done in it. But it wouldn't change whether I gave oxytocin or not just because it had a thickness. Certainly, if that's what you're asking, I think there is an advantage on the labour ward in certain, what I call obstetric abnormalities. I use that respectfully, but the previous scar or a breach or whatever, you have to be very, very, very simplistic and accept that you may be overdoing it, you may be underdoing it. Because it's a simple message to communicate to staff and a simple message between patients and yourself, and patients need to understand it.
There's a question there. Other two there.
But what does people think about the concept? Because the concept is what I'm trying to put forward. Whether it's 2 hours or 3 hours oxytocin is relevant. It's the concept.
I wanted to comment about the concept and not to the clinical details
Exactly,
of that. Yeah, so I have a different opinion. I think life is complicated. And what we are trying to do is making it simple. What you are trying to do. Yeah. So you're saying 2 hours of oxytocin, but this is based on no data. This is what you've agreed in your unit. And we know that on majority of things that we're doing in obstetrics, there are no certain data. And that's why it's so difficult to make things simple. And I think simplicity is something that maybe you can reach in your unit. But you have to have all people agreeing on things, on what to do. So what I'm asking you, I don't think simplicity is reachable worldwide. I think can be reached in a unit. In your unit, you manage to reach it. I think it's very difficult to reach it in an Italian unit because you have 20 different consultants having 20 different opinions on how things should be made. And nobody can really say things must be made like that because you will always find somebody that is like opposite in Europe. So how did you manage to make these things simple in your unit and everybody agreeing in a way of doing things that maybe shouldn't be in the same way for everybody? Actually.
There's a number of things. First of all, I don't know how many of you heard Monica's lecture today. It was a fantastic lecture on vaginal operative delivery. And Monica's working at the moment in National Maternity Hospital with us. I think you raise a number of very important issues. We've agreed on a lot of things. I think we could agree on more in our unit. And I think that just because you have agreed on certain things, in any unit it can slip. Okay? That's the first thing. The second thing is, let me put it to you. If you got everybody to agree and everybody came to you and said, you're the boss, Monica, we have all come together and we are going to agree and do this, is that necessarily a bad thing or would you accept it? What I'm trying to say to you, is the problem actually getting everybody to agree or the actual concept itself? I think you've raised a point about a difficulty in getting everybody to agree. I agree with that. But if I said to you, everybody came and said, I heard that guy talking, that's a very good idea. We're going to agree something. It doesn't really matter what it is, but we are going to agree something. Would you accept that would be a step forward?
Yeah.
Thank you. But you are right about the difficulty. And just because one unit has agreed, that can slip.
Domanda in mezzo.
I'm sorry, coming back to the VBAC about you wrote that if there's no spontaneous labor, you are planning the C-section after 41.
Yeah.
About induction, because we are not allowed to have prostaglandins, you are not mentioning about mechanical induction or membrane sweeping or something. What is your opinion? Because in this way we lose a lot of patients that could have a vaginal delivery.
Yeah, but it's the risk-benefit ratio. and in a 41-weeker with a previous scar who is unfavorable, yes, by all means try it. But then it becomes difficult. And you try it and write up your results and let us know. And if you've got very good results at 41 weekers with a previous scar, and we would be interested in that. What I suggest is that, from our data at least, it's very difficult. There's a lack of clarity. You can't have simple messages. It will be a time period going on and on. People come on shift, people go off shift. The first person that made the decision for the induction is not there later on. There are all kinds of organizational issues that blend into that. But if the results are good, the results are good. So I don't disagree with you, but results are important.
C'era un'ultima domanda,
Sì, in
forse?
fondo credo.
Sì.
Yes, always in relation of VBAC, I wish to understand if I have understand well or not.
Yeah.
Because I understand that starting from the labor to the delivery, there is maximum 6 hours, because there is amnioexis at the starting of the labor, then 4 hours of waiting, then 2 hours of oxytocin.
Yeah.
Yes, and I think it's not too easy to do an audit of each case only in relation with these 3 simple rules. So I think that the difference between Michael Robinson and me is the brain. So there is the thinking about the single case, no? And also which is behind the single case. It's not too easy to reduce the labor and the delivery in 3 action.
Yeah, so I'm not quite sure what I understood the question or not, but I do agree, and I think the brain wouldn't be in my head, the brain will be more in the individual case, and I think you're right in terms of maybe treating everybody as the individual case. The problem is our results are what they are, 2012, and those kind of figures. We've got to do something about it, and otherwise we're just going to go on like this. I don't think things are improving. Does everybody think things are improving? So, in a way, the individual case, yes. But if you've got an individual case and an individual obstetrician following that case, you could argue that that may work in terms of one person taking responsibility for it. The problem is the labour ward doesn't work like that. And often you've got a lot of different people. And I'm concerned about that practical issue of not having a simple culture, message, philosophy, wherever it is on the spectrum, for those kind of cases. I've selected those cases, shoulder dystocia, the use of oxytocin, VBAC, and I'm not really making a case for how we manage VBAC. I'm more making a case for having a standard way of doing things. That's really what I got. And I'm not trying to say that I'm right and everybody is right, but I want you to go, one of the purposes about a lecture like this is to make people think. And I say to all of you, if we all had a simple, clear way of thinking, philosophy, that everybody, if you ask them what do you do for that, they all come out the same answer. It actually doesn't have to be the same in different units, provided it's the same in any one unit. Would that be a benefit?
Thank you, Mike.